Welcome to The Explainer. Today, we're tackling something that terrifies a lot of us, the intimidating math and physiology of acid-base disorders. Let's be real, nobody went to medical or nursing school to do complex algebra, right? But if you've ever stared at a lab report and just felt totally overwhelmed by the numbers, you are absolutely in the right place. We're going to build a robust, repeatable system today that works every single time.
We've got a really clear roadmap for today. First, demystifying acid-base disorders. 2, 6 steps to ABGs. 3, the net neutrality principle. 4, calculating the anion gap. 5, correcting for low albumin. And finally, 6, high versus normal gaps. Basically, we're moving from the macro landscape of general analysis straight down to the micro investigation of specific metabolic disturbances.
All right, Section 1, Demystifying Acid-Base Disorders, the Clinical Reality. Let's dive right in and anchor ourselves in a clinical setting we all know so well.
Now, everything we're going to calculate today starts right here, with a totally routine blood draw. But, while it looks simple on the surface, what we're really doing is peeking into this massive, hidden physiological battle happening inside your patient. We're literally hunting for the invisible push and pull of acids and bases that totally dictate how well those cells are functioning.
Moving on to Section 2, 6 Steps to ABGs, the Detective's Manual.
Okay, to solve the mystery of what's happening in that blood, we need our macro tool first, and that means knowing our baselines. Memorize these ranges, because any deviation is your first major clue. Just as a quick refresher, normal blood pH sits super tightly between 7.35 and 7.45. For the respiratory side, your PCO2 is 35 to 45, and on the metabolic side, your bicarbonate is 22 to 26. These core ranges, they are basically the border walls of your entire investigation.
So those baselines plug right into a rigid 6-step protocol. This keeps you from getting totally overwhelmed. Step 1, check that pH. Is it acidic or alkalotic? Steps 2 and 3, you're evaluating the PCO2 and bicarb independently to see which one is out of bounds. Then, step 4 is the magic moment. You match the abnormal lab value with the pH. Like, if the pH is acidic and the PCO2 is acidic, boom, you've got a primary respiratory acidosis. Step 5 asks a really cool physiological question. Is the other system trying to help out? If your CO2 or bicarb goes in the opposite direction of the pH, that's your body desperately trying to compensate. And finally, step 6, always, check your oxygenation status.
So here's the crucial point. Once those 6 steps lead you to a diagnosis of metabolic acidosis, well, what's causing it? It is definitely not enough to just say, hey, the patient has metabolic acidosis. We need to know exactly why so we can actually fix it.
That brings us to Section 3, the net neutrality principle, the body's seesaw.
To track down our culprit, we have to look at a fundamental rule of human physiology. The body is an absolute constant balancing act. Think of it like a physiological seesaw where positively charged cations and negatively charged anions absolutely must perfectly cancel each other out. Your blood plasma is virtually always net neutral. If a positive charge enters, a negative one has to balance it, or another positive one has to leave. It's a strict law of nature, and it's the entire foundation for our next investigative tool.
Section 4, Calculating the anion gap, finding the unmeasured.
Since we know the blood is perfectly balanced, we can actually use this brilliant, kinda imperfect lab calculation to our advantage. If you chart out our primary measured cation, which is sodium, against our 2 primary measured anions, chloride and bicarb, you instantly see this empty space. That space represents unmeasured molecules. You see, we don't routinely measure every single tiny particle in the blood, things like phosphate, sulfate, or different proteins, so our basic math naturally leaves a gap. We can actually isolate that empty space with a really simple core equation, proving that there are normally 8 to 12 unmeasured anions just floating around, keeping the blood net neutral. You just take your measured positive sodium and you subtract your measured negative chloride and bicarbonate. That resulting number? That's your anion gap. It's literally just a reflection of those hidden negative charges, keeping that seesaw perfectly level.
And now, Section 5, Correcting for Low Albumin, the Plot Twist.
Okay, here's where we hit a massive, often missed clinical plot twist that can completely derail your diagnosis. Remember those hidden, unmeasured anions we just talked about? Well, albumin is a major one. It's a protein absolutely covered in negative charges. And if your patient's albumin is low, which, let's be honest, is incredibly common in critical illness, you absolutely must multiply their albumin deficit by 2.5 to correct your gap.
Listen,
If you skip this specific correction on a patient with low albumin, you're going to calculate a falsely normal gap and totally miss a dangerous underlying pathology. Here's how it works. A normal albumin level of 4. So for every point below 4, you add 2.5 to your calculated gap. So say you calculate a gap of 11. You might look at that and think, oh, that's normal. But if the albumin is 2, you have a deficit of 2. Multiply that by 2.5, which is 5, and add it to your gap. Your 11 is actually a 16. Suddenly, you've got an anion gap metabolic acidosis that you almost completely ignored.
Finally, Section 6, high versus normal gaps, the final diagnosis.
All right, once we have our safely corrected number, we can finally split our metabolic acidosis into two distinct pathways. And this side-by-side contrast is huge for both your exams and your actual practice. A high gap means extra newly introduced acids are actively eating up your bicarb. The acid basically dumps hydrogen ions into the blood, and your bicarb sacrifices itself to neutralize them. This shrinks the measured bicarb and widens the gap. A normal gap, on the other hand, means bicarb was simply lost, maybe through the GI tract, and chloride immediately stepped right up to take its place. Because the chloride rises exactly as much as the bicarb falls, the math stays perfectly neutral.
So, what causes a high gap? Whether you're a fan of the Goldmark mnemonic or mud piles, these are the actual unmeasured acids driving up that number. We're talking lactic acid in septic shock or keto acids in diabetic ketoacidosis. Every single one of these sneaks a positively charged acidic molecule into the bloodstream, which forces the bicarb down and blows that anion gap wide open. As we wrap up this explainer, you can see how all these pieces fit perfectly together on this cheat sheet. We moved from the macro ABG steps right down to the micro anion gap formula. We started with a simple pH, worked our way through the respiratory and metabolic sides, identified compensation, and then deployed the anion gap to hunt down the exact acidic invaders hiding out in the blood.
I'm going to leave you with this final thought for your next shift. If the body fights this hard, employing complex chemical buffers and shifting massive amounts of chloride just to keep the math of net neutrality balanced, what other hidden, unmeasured compensatory systems are just waiting for you to deduce them? Keep questioning the numbers, keep looking for the unmeasured, and definitely keep learning.